He is one of the pioneer endocrinologists of Bangladesh. He is a professor of endocrinology currently in the working at Bardem, and he is the president of Bangladesh Endocrine Society. Professor MD Farooq Pathan, sir. Professor MD Farooq Pathan, can we start the session, sir? Professor Farooq Pathan, can you hear me?
Sir is muted.
Okay.
Can you hear me? Can you hear me now?
Yes, sir.
Thank you. Thank you very much, Professor Tohit, for introducing me as a chairperson of this today's session. I think you can continue the moderation of the whole program. I think the erectile dysfunction is one of the important issue nowadays. It is ill focus, I think so, in the throughout the world. This subject, and there's lots of things are here to know the things. It is a multidisciplinary approach management, and it is also indicate one of the important issue of the metabolic disorder on the background, and herald the importance of the CV risks in the future. So there's lots of things here we have to hear from today's symposium. I request Professor Tohit to continue the moderation of the whole program today, and I think so everybody will enjoy the whole program. Thank you very much.
Thank you, Professor Pathan, sir. Now I introduce our today's guest. You know, the most eminent urologist and andrologist in this subcontinent, Dr. Rupin Saha. He is with us today as a special guest. You know, he dedicated himself to andrology as a super specialty that he deals with the male infertility and importance, and he was also the past president of the SASSM. He will be the Rupin Saha, will be the today's special guest, and another special guest, Professor Dr. T.S. Satyanarayan Rao. He is the professor, Department of the Psychiatry, JSS Medical College and Hospital, Mysore, India. He is the editor, Journal of the Psychosexual Health, editor and chairperson, Publication, Research and Educational Committee, South Asian Society for the Sexual Medicine. He is also with us today. And also Professor Dr. Yoshikazu Sato. He is the Domestic Secretary General of the World Meeting of the Sexual Medicine 2020-21. He is the Secretary General of the Japanese Society of the Sexual Medicine, Board of Director members of the ISSM, Clinical Professor of the Sapporo Medical University, Japan, and Director of the Sanjukato Hospital, Japan. I welcome you all the special guests in today's program. And the today's panel of experts is the three eminent faculties from the different specialty, like Professor Habibur Rahman. He is the Professor of Urology, Bangabandhu Sheikh Mujib Medical University, and he is also the proctor of Bangabandhu Sheikh Mujib Medical University, and currently he is the President of Bangladesh Association of Urological Surgeons. Welcome, Professor Habibur Rahman, as a panel of experts today. And today we another panel of experts. He is a very well-known psychiatrist in this country, very renowned person, though he is a army personnel. Brigadier General Professor MD Azizul Islam. He is the Vice President of Bangladesh Association of the Psychiatrists. And another eminent endocrinologist of this country, he is Dr. Firoz Amin. He is working as Associate Professor of the Endocrinology Bardem. He is also with us as a panel of experts. Now I introduce the speakers. Earlier I said we learn a lot today from our speakers about the way of diagnosis, approach to the diagnosis, treatment and complication of the treatment, and so many things of the erectile dysfunction. You know, currently, not only the COVID pandemic, stress, anxiety, there is a non-communicable disease is progressively rising in our country also and in the Southeast Asia. So there is so many etiological factors for developing ED. And you know, erectile dysfunction sometimes may be the hidden, maybe the symptoms of the hidden disease of the cardiovascular disease, diabetes mellitus, and dyslipidemia, and so many things. So now we will introduce our speakers. Professor Dr. Christopher Ho Chi Kong. He is an adjunct professor of the School of the Medicine, Taylor's University, and consultant urologist and Oriental Malacca States Medical Center, Malaysia. He was previously professor of surgery and urology at University Kebangsaan, Malaysia. And our another speaker is a very renowned speaker in this country. He is a renowned endocrinologist working at the Bangabandhu Sheikh Mujib Medical University as Associate Professor of Endocrinology. He is an editor of so many journals. He presented in so many seminars and workshops. Dr. Sajid Salim, he is very much he is the associate professor of endocrinology of Bangabandhu Sheikh Mujib Medical University, and he is also the organizing secretary of the Bangladesh Endocrine Society. And our another speaker, he is a very renowned psychiatrist in this country. He is working in Mymensingh Medical College as assistant professor with psychiatry, Dr. Polastra. And today we have with us the patron of the sexual medicine of the Bangladesh, rather I say, who organizes the sexual medicine in this country, who accumulate the urologist, endocrinologist, diabetologist, and obstetrician, also the sexual and skin and venereal disease specialist, and other pharmaceuticals members to organize the sexual medicine in this country. He is Mr. Musaddiq Hussain. He is the managing director of the UniMed, UniHealth. He will give the vote of thanks. So, friends, no more talks. Now I invite the Professor Dr. Christopher Kong to for his talk on overview of the erectile dysfunction. Dr. Kong, please.
Thank you so much for the introduction, and it's a great pleasure for me to be here to share my knowledge.
I request all the speakers, please be in time within 12 minutes. If anybody want to ask any question, please give your question in the chat box. Then we'll later on discuss. Sir, please go ahead.
Can I share my screen?
Yes, yes, please.
Okay. Yeah, good evening, everyone. So my job here is to give an overview of erectile dysfunction in 10 minutes. So I'll go very quickly. These are my disclosures. So what is erectile dysfunction? Erectile dysfunction is defined as the persistent inability to attain and maintain an erection sufficient to permit satisfactory sexual performance. So before we go into what erectile dysfunction is, we need to know the anatomy and as well as physiology of how erection happens. So the penile anatomy, the penis is actually supplied by arteries, which are actually the branches of the internal pudendal artery. And this includes the two dorsal arteries, as well as the cavernous artery, bulboutero artery, as well as the circumflex artery. And for the drainage of the blood vessel, the drainage of the penis is actually through these emissary veins, which then travels into the subtunical venous plexus, and then it drains into the dorsal vein. So what is important to notice here is this subtunical plexus, which is actually sandwiched, is positioned sandwiched between these sinusoids or the corpus cavernosa, as well as the tunica, which is outside. So it's sandwiched in between and can be easily compressed. So what happens during erection in erect state is that there is relaxation of smooth muscle causing the blood vessels to vasodilate, to enlarge, and this causes increased blood flow into the penis, into the corpora cavernosa, into the sinuses. And when these sinuses gets filled up with blood, it becomes engorged and filled up. It will actually compress this subtunical venous plexus against the tunica outside. And therefore, more blood comes in, but blood can't drain out. So this helps to give you the full turgidity erection, as well as maintaining it. And when flaccidity happens, what happens is that there is vasoconstriction. The blood vessels constrict, blood flowing into the penis is actually restricted, and therefore this space becomes less congested with blood. Therefore, it contracts, and this subtunical venous plexus is able to expand and drain out the blood. So when blood is drained out and very little comes into the penis, that's when you get actually the flaccidity. At the molecular level, what happens is that sexual stimulation actually causes the cavernous nerve to release nitric oxide. And this nitric oxide will then stimulate this guanylate cyclase enzyme to convert GTP to cGMP. So cGMP is the key here. cGMP is the key here, which will then cause decreased calcium and smooth muscle relaxation. So cGMP is broken down by PDE5 enzyme into 5-GMP. So to maintain and to help good erection, you can actually try to maintain this cGMP, prevent the breakdown. And this is where PDE5 inhibitor drugs works. Now, ED prevalence, as you can see from this slide here, it increases with age, and at the age of 70 is almost 50%. The prevalence of erectile dysfunction is expected to increase from 152 million men in 1995 to 322 million men in 2025. So you can see here for Asia, it's expected to increase a lot, up to 113 million by the time it comes to 2025. So what are the risk factors for erectile dysfunction? One is, of course, aging. When we age, there's progressive functional loss of tissues. There's also psychological problems which can contribute. Besides that, other risk factors include chronic diseases like hypertension, diabetes, depression, as well as cardiovascular disease. So diabetes is an important thing which will be discussed later on by my next speaker, Dr. Salim. Medications as well, certain medications can also affect erection, and this includes things like antihypertensives, thiazide diuretics, as well as beta blockers are known problems when we are treating patients with hypertension, and also lifestyle. So stress, which we are seeing now more and more because of this COVID and as well as this pandemic and the lockdown throughout the world. Even in Malaysia, we are getting a lot of patients who have stress, and I see a lot of them coming in with erectile dysfunction. Excessive alcohol use, smoking is also another bad thing to do, drug use, as well as nutritional disorders. So why should we diagnose erectile dysfunction? Although erectile dysfunction is a benign disease, it also has negative effects on men. And one way it affects is through psychosocial. It can cause depression, anxiety, feeling of emasculation, that means they don't feel like they are men anymore, reduce self-esteem, and then they reduce productivity because they can't perform sexually, and all this stress causes them to affect their productivity. Business life will also be affected. And also, this also causes a decrease in the sexual quality of life in men. But what is more important is not just the psychosocial aspect. What's more important is that erectile dysfunction is actually an early warning sign. It's an early warning sign that something is not right with the body. And a lot of other problems are associated with this erectile dysfunction and needs to be diagnosed. And this includes coronary artery stenosis, diabetic peripheral neuropathy, retinopathy, hypertensive cardiomyopathy, as well as stroke. So the penis can be taken as a health barometer. So when a patient comes with erectile dysfunction, don't just think about the penis, don't just think it's a psychosocial problem, think of the man as a whole, and think of other problems, like especially the cardiovascular health, which can be affected or in the future can be affected in this type of patients. So it is an opportunity for us to actually advise patients to go for further checkup and to treat all the underlying illness, which can help the erectile dysfunction, and also not only that, help to prolong their lives, prolong their survival, prolong their healthy life state. So erectile dysfunction is not only a problem which affects the man alone, it also affects the lady, and it also causes sexual problems in women. So it's not a single thing, it also affects the partner. So it's not a one problem, it's a problem which affects at least two people. And how do we diagnose erectile dysfunction? Erectile dysfunction is actually a clinical diagnosis. There's not much of investigation needed. It's mainly a clinical diagnosis, but we can use this questionnaire called the IIEF questionnaire, the International Index of Erectile Function, to diagnose as well as to classify the severity of the erectile dysfunction. So when a patient comes to you with erectile dysfunction, which most of the time is a clinical diagnosis, we can also use the IIEF questionnaire to help to classify the severity. Then we actually try to identify other common causes of erectile dysfunction, like the hypertension, diabetes, and so on, identify the reversible risk factors for erectile dysfunction, assess the psychosocial status as well. Then we go and do a quick physical examination, look for any penile deformities, any prostatic disease, signs of hypogonadism or cardiovascular and neurological status, and finally do some blood tests. The simple blood test that's needed is glucose as well as lipid to look for diabetes or hyperlipidemia, and also to look for hypogonadism. We can actually do the total testosterone level as well. No other further test needed. It's a very simple diagnosis, very simple test which is needed. So in terms of treatment, very quickly, the treatment for erectile dysfunction, of course, we need to identify and try to treat the risk factors. Okay, if they have diabetes, hypertension, then you need to treat the patients and control the hyperlipidemia, the diabetes. We need also to have proper education and counseling. We need psychosexual counseling as well. And I think this will be mentioned by Dr. Rao in the next lecture. Once we have done that, then the first line for treatment is actually PDE5 inhibitor. All right, it's a grade A recommendation with level of evidence 1A. Other treatment that can be used will be intravenous injections, vacuum devices, intrauterine topical prostadil. And when all this fails, all right, if after it fails, then the last treatment, which has been found to be quite satisfactory, is actually penile prosthesis. But that is a last resort because it involves major surgery. A new treatment modality which has come in the recent years is actually this low-intensity shock wave, where you give shock waves to the penis over a period of a few weeks. And the proposed mechanism is that this shock wave causes mechanical as well as biochemical response, causing release of these endothelial growth factors and so on, which then causes vasodilation as well as angiogenesis, causing neovascularization. And that is how it's supposed to help with this erectile dysfunction, improving the blood flow, improving the nerves as well as the tissues which are in the penis. Others include stem cells, which is still experimental at this time, and also complementary traditional medications, which do not have conclusive evidence at the moment. So in summary, erectile dysfunction prevalence is actually increasing worldwide, especially in Asia. Erectile dysfunction should be taken as a barometer of health. We need to use it to actually identify patients at risk for other diseases and help to treat them for the other diseases as well. In terms of treatment, of course, the first thing that they should do is healthy lifestyle. Healthy lifestyle includes stop smoking, moderate exercise, and also to maintain a good body weight. Psychotherapy and counseling, which will be discussed later on by Dr. Roy. Medications, the first line is PDE5 inhibitor. Then other medications that can be used include intravenous injection, vacuum pump, penile prosthesis, as well as the new one, shockwave, low intensity shockwave. And with that, I thank you.
Thank you very much, Mr. Kong, for your very comprehensive presentation and lecture on overview of the erectile dysfunction. So you should be with us. So if you have any question from the audience or participant, we'll discuss later on. Thank you very, very much. So now I invite Dr. Sajid Selim. He is the Associate Professor of Endocrinology. He will talk on management of the erectile dysfunction in diabetes mellitus. Dr. Sajid Selim, please.
Thank you, Dr. Tohid, for the kind introduction. Very good evening and welcome to my part of discussion today. The chairperson of the session, Professor Farooq Pathan sir, the mentor of my endocrine career in Bangladesh, very well-known person, and the eminent experts and guests from home and abroad, and the senior physicians who are working in the field of sexual medicine, who all gathered together. I am very much grateful to them, and the most gracious presentation of the participants. I think they will be very much enthusiastic to learn. I am presenting briefly, so we can go for discussion later on. My slides are visible?
Yes, you are visible.
Thank you, sir.
And also audible.
So my management of erectile dysfunction in diabetes, I have nothing to disclose. So one thing I like to start with the erectile dysfunction and diabetes mellitus, the notorious duo, because from Dr. Christopher Ho, we all also heard that diabetes can play havoc with the patient with erectile dysfunction. And in the other situations, diabetes has also contribution, also the management and quality of life. So if we look into the summary of epidemiology of erectile dysfunction in men with diabetes, we can find that it may range from 35 to 90%. And in Bangladesh, we published data, myself along with Dr. Shamsur Hassan and others were there. We found 76.4% patients with diabetes with duration of more than 2 years had erectile dysfunction. Sri Lankan data found 73.2%. USA data 49%. So we can find that the huge number of patients of diabetes mellitus, they are male patients suffering from erectile dysfunction. Erectile dysfunction is 3 to 4 times more common in men with diabetes compared with non-diabetes. Erectile dysfunction occurs about 12 years earlier in men with diabetes. Erectile dysfunction in diabetes is more severe than erectile dysfunction in non-diabetes and more difficult to treat. Erectile dysfunction can be presenting symptoms of diabetes in some men, particularly in the elderly, and some study found that around 11 to 13% patients who reported symptoms of erectile dysfunction, they had diabetes, but they did not know. And one thing focused by Christopher Ho, and I would like to emphasize on that, the men with type 2 diabetes mellitus erectile dysfunction has greater risk of cardiovascular events with type 2 dysfunction, type 2 diabetes mellitus without dysfunction. So it can be taken as the baseline investigation for screening for atherosclerotic cardiovascular diseases. Now, depending upon the scoring system used, we can compare the erectile dysfunction with non-diabetic population in South Asian, European. We can find that depending upon the scoring system, there is a gulf of difference, but it is obvious that the number of erectile dysfunction among diabetes population actually is double or 3 times more than the non-diabetic population in the globe. Very important thing to keep in mind that as the diabetes duration advances, that will increase, that will have the increased chances of erectile dysfunction among men. We can find that at the 0 to 4 year duration of diabetes, up to 24% have 24% erectile dysfunction. Among the 5 to 9 years group, it is up to 38%, 10 to 14, 32.4%, 15 to 19, it is about 41%, 20 to 24, 60%, and diabetes duration more than 60 years, among them almost 100% men have erectile dysfunction. So in our country, many of the male coming to physician repeatedly, they have long duration of diabetes. If we do not address those population, as many of them are not coming with the symptoms or any complaint of erectile dysfunction, so we may miss to diagnose those cases. Pathophysiology of erectile dysfunction in diabetes, particularly, I should say that the associated comorbidity, hyperlipidemia, especially hypertriglyceridemia. We have published data from also Bangladesh that the hypertriglyceridemia has the prominent association of causing erectile dysfunction in men, as well as hypertension, obesity, and sedentary lifestyle. During this COVID pandemic, almost all of the people of the world are advised to not to go out. So everybody is passing the sedentary lifestyle. But beyond this, we also are very much accommodated with the sedentary lifestyle that has contributed to cause erectile dysfunction in diabetes mellitus. The main culprit of diabetes mellitus and erectile dysfunction is the deficiency of nitric oxide and increased level of nitric oxide synthesis and AEG level. This too has the dominant effect of causing erectile dysfunction, and drugs are also devised to combat this one. So we can say that the PDE5 inhibitor, that phosphodiesterase inhibitor, that degrades the nitric oxide level and causing cavernosal muscle less effective. PDE5 can reverse this action. Diabetic population has the higher chances of having neuropathy, that will also contribute, especially autonomic neuropathy will contribute to cause erectile dysfunction. So as well as diabetes also has the low level of testosterone, total testosterone, and testosterone binding globulin, that will also contribute to cause erectile dysfunction. And local factors can also be a pertinent part of pathophysiology of erectile dysfunction in men with diabetes. So we should consider everything. And the depression, anxiety, libido, I am not going in detail. That will be discussed by the following speaker. So everything will cause vascular, neuropathic change, and erectile dysfunction in men with diabetes. Now, evaluating and management of diabetes, as we do not have huge time, I am going to make it shortcut. For the patient with diabetes, every step of detecting the status of glycemia should be done. Not only that, the other contributing factor and comorbidity should be clearly detected and addressed. And the patients with diabetes, they have also higher chances of having diabetic dyslipidemia. As I said, elderly that the hypertriglyceridemia is the most important culprit. But while addressing the dyslipidemia, several studies found that if we use the atorvastatin, that may cause the aggravating the erectile dysfunction. But if we use rosuvastatin, that can preserve erectile function in men with diabetes mellitus. So this can be used. We are also conducting study here to focus this area. The cardiovascular systems of all patients with diabetes mellitus and erectile dysfunction should be evaluated minutely, because that will contribute to choose the appropriate drugs for the patient with erectile dysfunction. Now, this part, the categories of treatment, the first line, second line, and third line therapy. The lifestyle modification is very much important, not only for diabetes, to have the active lifestyle to reduce the excess body weight, and maintaining the body weight and physical activity will have appropriate erectile function in men. And the medication adjustment, psychological input, oral drugs, and vacuum devices that can, by coming one by one, I am coming with a very short description of oral drugs. Second line therapy, that are intracavernosal injection and intraurethral alfosterone. Third line, penile implants and vascular reconstruction that are also only done by urologists. The mainstay of treatment is the specific PDE5 inhibitors. As I said, elderly, that the decreased level of nitric oxide that will have the decreased action of cavernosal muscle, and not only that, this nitric oxide activity will be inhibited by phosphodiesterase, and the inhibitor of this phosphodiesterase that can preserve the improve the activity of cavernosal muscle and can improve the erectile function in men. But non-specific PDE5 inhibitors like papaverine can also be given, but systemic effects will be more in those cases. The four PDE5 inhibitors in Bangladesh, this is sildenafil, vardenafil, and tadalafil are available. Avanafil is not available, and we can see that the effects of these four are not similar, but the judicious use of the drugs can improve the quality of life. But for diabetic population, the PDE5 inhibitors have the pronounced action than non-diabetic population. But before going to start PDE5 inhibitor, we should practice precautions. As many of the patients may be on nitrates, so there should be 24 to 48 hours gap of PDE5 inhibitors and nitrates. And guanylyl cyclase activators should also be considered. Protease inhibitors, alpha blockers should also be considered in those patients, and we should consider that while we are going to start the drugs or not. The side effects, this also be conveyed to the patient. If we do not tell about the side effects, patient may feel discouraged or discontinue drugs. These are the headache, facial flushing, GI symptoms, especially heartburn, nasal congestion, visual disturbances, diplopia, and blurred vision, and chromatopsia. That this all can happen. Now, while
you have 1 minute left.
Okay. Starting the drugs, while we are choosing PDE5 inhibitors, the sexual frequency and duration of sexual intercourse should be considered. Then the other devices, the vacuum device is the oldest one, but it is not commonly practiced now. The intracavernosal injection, it is not preferred by the patient, but can be given who fail to improve with the PDE5 inhibitor. Then the intraurethral PDE1, it is also not very much comfortable for the patient, so we are not going to use very commonly. The surgical treatment of this one is just also very specific for urologists or endocrinologists. They are doing this one. Now the implants also has as the last resource. may be given, and many of the instances patients do not prefer this one. So these are the implants. So at the end, I can summarize by saying that the optimum glycemic control along with lifestyle modification is a cornerstone of erectile dysfunction management in diabetes. Targeted patient counseling and initial medical therapy constitute the basic management step in erectile dysfunction. Oral PDE5 inhibitor constitutes the first-line therapy, and it may require few weeks to time to achieve significant benefit of PDE5 inhibitor, and some may not benefit at all. This should be also considered by the physician and also disseminated to the patient. Thank you all for the patient hearing, and we are in the peak of COVID pandemic. Stay home, stay safe, and serve the nations to have the better outcome of COVID pandemic. Thank you all.
Thank you, Professor Sadar Salim, for your very nice presentation regarding management of the ED in diabetes mellitus patient. Thank you very much. Thank you again. If you have any question from the participant, we will talk with you later on. Please stay with us. Now I invite the Dr. Palasa. You know, earlier I said the most of the patient of ED suffer either it is the cause of the ED as a anxiety, depression, and stress, or maybe patient undergo the stress, depression, or anxiety due to ED. So you need to evaluate the patient properly as a history of psychosexual history, proper social history, sexual history, and ultimately a patient may need the psychosexual counseling. So now we hear from the Dr. Palastroy, the psychogenic ED, how to assess and manage. Please, Dr. Palastroy.
Thank you, sir. I'm sharing my screen. Is it visible, sir?
Yes.
Okay. Good evening. I'm Dr. Palastroy, inviting you all to my today's presentation on psychogenic erectile dysfunction. And well, we already know the prevalence and incidence of erectile dysfunction is high worldwide, and higher prevalence were found on the US and Eastern and Southeastern countries in comparison to Europe and South America. According to Massachusetts male aging study, which is one of the milestone studies in this field, showed a combined prevalence of mild to moderate erectile dysfunction is about 50% in men aged 40 to 70 years. And it is also estimated that about 10 to 20% of erectile dysfunction has a purely psychogenic origin. It is well established now that erectile dysfunction is a condition that is more prevalent in older population, and recently it has been found that in real life setting, 1 man out of 4 seeking medical help for ED is less than 40 years. Like premature ejaculation, most of the causes for which young people are suffering from erectile dysfunction has psychogenic origin. And regarding the organic ED, most of the cases has psychogenic cause also along with the organic cause. And that's why we have to know more about this issue to ensure optimum care to the patient suffering from ED. Psychogenic ED was defined by the International Society of Sex and Importance Research as the persistent inability to achieve or maintain an erection satisfactory for sexual performance owing predominantly or exclusively to psychological or interpersonal factors. In psychological ED, the physiological erectile mechanism are found intact, and the ED is caused by psychogenic inhibition, and this can be happen when a man has a negative expectation or fear or failure on his mind during the excitation phase. Stimuli sent from the brain to the sacral spinal cord can inhibit the reflex erection. On the other hand, excessive sympathetic tone due to any cause like stress or anxiety with elevation of circulating catecholamines can increase constrictive tones and counteracting the mechanisms that cause relaxation of the cavernous smooth muscles and thus prevent the erection. We know that different psychological factors have a crucial role on developing ED, and it is often thought a secondary reaction to an underlying physical cause that can cause psychogenic ED. In some cases, the psychogenic ED may stem from childhood abuse or sexual trauma. And however, the most common causes of psychogenic erectile dysfunction are stress that can be job-related, money-related, and the result of marital problem. And nowadays, COVID is the big factor to develop psychogenic ED. Another thing is anxiety, the thought that once a man experiences erectile dysfunction, they may become overly worried that the problem will happen again. And this can lead to performance anxiety and consistently lead ED. The guilt is the another thing, and it may be due to the thought that they are not satisfying their partners, and this kind of thought can lower the person's self-esteem and ultimately can cause ED. And the depression is the common cause of erectile dysfunction, and it can affect a person both physically and psychologically, and can cause erectile dysfunction even a man is completely comfortable in sexual situation. The last thing is the indifference, and that may cause as a result of age and a subsequent loss of interest in sex, and it can be the result of medication or stemming from problems of couple relationship. About evaluation, the identification of the pathogenic factors involved in the erectile dysfunction is the cornerstone of an accurate diagnosis and treatment. And for a point diagnosis of psychogenic erectile dysfunction, aside from organic factors, psychogenic and relationship domain need to be evaluated. And as because the erectile dysfunction is a sensitive issue, so before going to sexual history, a clinician must be aware of the patient's comfort level, and taking sexual history provide an opportunity for the physician to initiate patients and partner education about erectile dysfunction and its treatments and to facilitate the communication. It is also allows the physician to establish a rapport with the couple and which assist in treatment. As because many physicians are not well skilled in sexual history taking, structured questionnaire like International Index of Erectile Dysfunction or Erectile Dysfunction questionnaire may be helpful. And a good sexual history should explore the educational and religious, the educational and the religious factor of the patients and the partners, and the current sexual relationship status that includes the frequency, aversive stimuli, sexual thoughts and fantasies, the erroneous sexual beliefs and of the patients and the partner, and associated sexual dysfunction, and the history of specific sexual problem. The psychological assessment should be done for anxiety, depression, phobias, obsessive disorder, and personality disorder that may related to the sexual problem. And the physical examination of the person includes evaluation of the chest, penis, prostate, testes, and distribution of body hair to exclude hypogonadism. And peripheral vascular system assessment is also important to exclude any vascular or hormonal cause of erectile dysfunction. And a few biochemical or hormonal parameters are of value in patient with erectile dysfunction. And the level of cholesterol, triglyceride, fasting blood sugar, HbA1c are important to rule out the diabetes and cardiovascular disease, and total testosterone and sex hormone binding globulin for the evaluation of calculated free testosterone are sufficient parameter to rule out the hypogonadism. And in some cases, parathormone and thyroid hormone should be evaluated. Though we know that in case of psychogenic erectile dysfunction, the physical examination and the lab evaluation are found are normal. The factors that best differentiates the organic from the psychogenic erectile dysfunction that causes is the presence of morning or nocturnal erections reported by the patients, and the presence of an erection in non-coital sexual circumstances such as foreplay or masturbation can also be assessed. Other aspects that should be taken into account are age, and we know that the younger peoples are suffering from psychogenic ED more, and the mode of onset of erectile dysfunction, which is usually abrupt for psychogenic erectile dysfunction and slow and subtle for the organic ED. A careful assessment of these aspects together with the patient's medical history and attention to risk factors can provide a reliable diagnostic discrimination to diagnose psychogenic erectile dysfunction. Now the treatment, and it can be assumed that the purely psychogenic erectile dysfunction has a good response to treatment, but before going to the accurate treatment, it is mandatory to perform a general intervention to any patients with erectile dysfunction, and that includes the reassurance of the patients. Appropriate sexual information should be provided to the patients and partner to modify any erroneous beliefs or expectation about their sexual act that may cause the erectile dysfunction, and advised to modify some reversible causes like smoking, alcohol intake, some drugs like antihypertensive or other antipsychotic medication, and sedentary lifestyle, etc. should be given, as because it is already established that modification of this factor can cause positive impact on erectile dysfunction treatment outcome. Now, the sex therapy, and it is the most important part of the treatment of the patient with psychogenic erectile dysfunction. And to perform this, the physician should be familiar with the basic principles of sex therapy. That includes the prohibition of intercourse, censored focus, voluntary loss of erections, or no expectation about the response. And success of the therapy, it depends on a number of conditions, such as the availability of a stable and cooperative partner, ability of both patients and partner to change attitudes towards sexual activity, a level of education sufficient to understand the cause of the problem, and the objective sought by the treatment, and absence of a severe underlying psychology in both. The sex therapy in psychogenic erectile dysfunction can be divided into an anxiety reduction and desensitization. This is designed to reduce the performance anxiety of a patient by avoiding intercourse in early treatment and using relaxation techniques. To reduce anxiety, instead of having coitus, the couple are trained to follow a series of non-genital, non-demand sunset focus exercise. And the ultimate goal of CBI is to teach patients how to change their undesired emotions, such as anxiety and fear, that result in maladaptive behavior. To achieve this, psychoeducation give to the couple, and so why they can overcome the unrealistic expectation regarding their sexual act. And the increased sexual stimulation technique is applied to improve sexual desire of a couple if the erectile dysfunction is arise from the desire of any one of the couple. And by interpersonal assertiveness and couple communication training, couples are able to express positive and negative ideas and feelings about sex to each other in an open, honest, and direct way. It allows the couples to take responsibilities of their own action without judging and blaming each other, and thus can resolve their relationship issues that is responsible for the erectile dysfunction. The pharmacological therapy is indicated when the patient or partner are not fit for sex therapy, when prior sex therapy has failed, or when the patient is too mentally blocked to attempt a psychological approach. On the other hand, pharmacological therapy can be used in combination with psychological therapy to obtain initial results that boost patients' self-confidence and help psychological treatment progress. If a clinician decides to add pharmacological option, the treatment of first choice is oral drug therapy. And obviously, the tadalafil is the best choice among the PDE5 inhibitor. And despite the proved efficacy of sildenafil, some patients may not use the drug correctly, and therefore it is important to give some guidelines about use of the PDE5 inhibitor. And before prescribing the PDE5 inhibitor, we should emphasize the need for sexual stimulation, as because we know that without stimulation, this drug, the erection will not happen. And we should explain that it is not necessary to take the drug exactly 1 hour before sexual activity, because this may cause problems in obsessive patient. We should give advice to the patient to avoid negative expectation about their intercourse, and we should encourage the patient to focus his attention on the erotic aspects and not on the outcome. Yohimbine can be another option for treating psychogenic erectile dysfunction, as it acts by blocking the receptors responsible for preventing erection. And different studies shows it is effective as sex and marital therapy for psychogenic erectile dysfunction. A second therapeutic option is intracavernous injection of vasoactive drugs. Self-injection of papaverine and phentolamine 4 times monthly shows 94% efficacy, although it requires prior training of the patient, and it should be keep in mind the adverse effect of this self-injected injection. So, and it reduces the anxiety. It is shows that it reduces the anxiety, and thus it increases the frequency of the intercourse, and also patient states that they get better sexual satisfaction by using these things. Actually, I'm just end of my presentation, but before saying goodbye, I have some take-home message, and it is one of the most common and the most distressing sexual dysfunction in men. And the onset of is sudden and maybe intermittent with normal nocturnal penile pubescence. And even after recent advances in pharmacotherapy, sex therapy remain the gold standard for psychogenic importance. And the psychiatrist has a crucial role to play in the evaluation and management of the erectile dysfunction, as he the only specialist who has an adequate knowledge of both organic and psychogenic cause of erectile dysfunction. With this, I would like to thank the organizer for inviting me to today's webinar. Thank you very much.
Thank you, Dr. Polasra, for your very comprehensive talk about the psychogenic erectile dysfunction and how to assess and management. Definitely, the participants are enormously benefited by your talk. So now we have some question in the chat box. Before going to the question in the chat box, I must give thanks to all 3 speakers because they present their talk within time. So thank you very, very much, all the 3 speakers. So my question to Mr. Kong first, how will going to take the sexual history and psychosocial history of a ED patient? What is the validated questionnaire for initial diagnosis of the ED?
Yeah.
Dr. Kong, please.
Yes, okay. So the questionnaire that can be used is the IIEF, or the International Index of Erectile Function, which I shown earlier on. This will give you the score and also give you the diagnosis of ED as well as the severity of the erectile dysfunction. But besides that, other things that we can actually inquire in the history would be things like how long has this erectile dysfunction been going on, whether it's something new or previously from the first time that they of sexual intercourse that they experience this erectile dysfunction. And the other thing that is important to find out is whether there is also the normal nocturnal erection. Okay, as mentioned earlier on in the other speakers' slides as well, the nocturnal erectile dysfunction will be able to help to differentiate between psychogenic as well as organic cause for the erectile dysfunction. And besides that, need to get further history regarding other diseases which they have, underlying diseases like diabetes, hypertension, hyperlipidemia, and cardiovascular disease, because treating these diseases may also improve their erectile dysfunction. And also we need to find out what medications that they are on also, which may affect their erectile function as well, and can be actually modified or changed accordingly as well. So besides that, I think what most of us also don't touch on, or sometimes we forget, is actually to take a slightly more detailed sexual history regarding things like whether this new experience that they're having erectile dysfunction is with because of a new partner in life, a new partner in their sexual life, and also whether they have other paraphilias as well. Especially if it is a erectile dysfunction which happens, they don't have problem with masturbation, they can still get erection, but when they are having sex with their partner, they can't get it. Could be things like paraphilias, where they get sexual stimulation from different ways, like or I think things like sometimes they are stimulated by touch, or by shoes, or by other bonding and so on. Or they could also be underlying problems, like they may actually be homosexual, and they can't bring it out because of the society as well as culture, and that's why they can't perform well with a normal lady. So these are important things I think we should take in the history.
So thank you very much. Thank you very much. My another question, this is also in the chat box. What advanced test you suggest for diagnosis the ED?
Yeah, from the chat box.
Like duplex ultrasound or cavernosogram or something like that. what you suggest and what is your likings in your practice setup?
So from the history and the physical examination, you will actually know whether it's a simple ED or it's not. If it's a simple ED, then you don't need any of these further special investigations. But in cases where it's equivocal, you're not sure, for example, patients who had trauma to the penis before, or patients who suspect having this psychogenic erectile dysfunction, or for maybe like court cases and so on, then you may need to do further investigations like penile ultrasound, penile duplex ultrasound to look for blood flow, as well as especially for increased venous outflow from the penis. That means they are unable to maintain venous leakage and they are unable to maintain their erection. So that will be a slightly different way of treating these patients. And these patients may not respond well to PD5 inhibitors. The other things, as I said, is penile deformities like the like Peyronie's disease and so on, or previous trauma, which can actually cause arteriovenous malformations in the penis as well. So, and the nocturnal penile NPT, nocturnal penile tumescence test, is also to differentiate between the psychogenic as well as organic erectile dysfunction.
Do you suggest sildenafil or intracavernosal papaverine injection prior to duplex ultrasound study?
Yes. I think if you really want to see what happens during erection, of course, if they can't get a normal erection, we may need to induce the erection by giving either an injection or give them the PD5 inhibitor to see whether the blood is actually flowing well and whether there's an increased venous drainage as well.
Which one you prefer, sildenafil or papaverine injection, and why?
Okay, so of course the injection is not dependent on stimulation, so it works in a different way. The ATP which is involved and not the CGMP. So and you get the erection without stimulation. So when you do inject prostaglandin into the corpora cavernosa, you should get an erection in normal cases. So of course the injection will be the best, but a lot of patients will not like it because you're actually injecting something to their penis. If they're not happy, then they can actually try to take the PD5 inhibitor. But I think the best is of course the injection.
Have you experienced after getting injection papaverine, a patient develop priapism?
So far, from my experience, actually, I'm quite lucky. I have not got any patients who got priapism. You just need to be careful, of course, with the dosage. And it's always important to the patients, the first time you're giving them, to give the test dose and to see how is their response. If they get very good response with a minimal dose, then don't try to increase too much the dose.
Okay, this is very grave complication of injection papaverine. So one thing from the chat box, I think during the erection, we use the PDE5 inhibitor. So PDE5 inhibitor, in another way, it maintains the erection. But if somebody have the venous leak, what is your treatment option? Is it PDE5 inhibitor or other things? Can you understand my question?
Yes, I understand your question. Yeah. So venous leak is not very common, but it does happen. And to actually diagnose this, previously what was done is actually to do the cavernosogram that you inject, and actually you see the venous flow in the venous leak. So in this type of patients, PD5 inhibitors most of the time do not work very well. And previously, the treatment of choice for this type of cases is actually ligation of the veins. But recently, there's been publications which suggest to use things which, like for example, like the new shock wave, which may be able to help in this venous leak as well. How about you, the other experts? Any opinion on this? Because it's not something very common that we see, and in terms of treatment, I think there's a lot of controversy regarding it.
Can I add something?
Firoz.
Yes.
Dr. Firoz, please.
Sure.
I'm coming to you, but earlier you want to say, please.
Just for the venous leak, sometimes there is some condom that has been used that can be act as a band in the lower part of the penis, and that can prevent some venous leakage. So many companies now use special condom for this problem. And normally, we used to tell our patient to use the condom. It's the lower part of the condom will be positioned at the lower part of the penis. That can help some of the patients with the venous leak.
Okay, thank you.
Thank
Thank you, Dr. Firoz. Now I am ask you another question, Dr. Firoz. It is in the chat box. How will we manage ED with the cardiac comorbidity, and which PDE5 inhibitor is safe in cardiac patients?
Oh, thank you very much. And for my patient of cardiac patient, normally I want to make them understand whether the sex is very much important for his family life, yes or no. And I want to make say some of the patients with the post-CABG patients, some of the patients with post-PCI patient taking so many drugs. And so first of all, I just make them understand whether really sex is important for you. Because as you know that diabetic patient, whenever they have developed vasculogenic change in the dorsal artery of the penis. So that causes the less blood flow of the penis. And the same change also happening in the coronary artery disease. So what drug I am giving to them, in fact, that will not be very much helpful for the patients. So already patients of cardiac patients also have atherosclerotic change in the penis. The best option should the vacuum device is the best option. And vacuum device is very much popular in Western people, in Western country, but not too much popular in our country. To my patient, I tell to collect from the outside the country. And these vacuum devices, some are battery chargers, some are handmade, just put over the penis, just pump in front of the vacuum device, the air will be out from the vacuum, then ultimately blood will be drawn in the penis will be strong, and there is another band available in the device that can be lugged in the lower part of the penis. So that is a very safe for this group of the patient. And still they are not happy with this vacuum device, then plan for the implant of the device what Dr. Shahzada has been told. Thank you.
Okay, thank you very much. Thank you very much. And now my question to the Professor Shahzada Salim. One question from the chat box from Mr. Tito. He said, ask the question, I have a patient with diabetes mellitus, control for the 10 years, suffering from the ED for 2 years. No response with tadalafil 5 milligram BD. With tadalafil 10 or 20 on demand, and also tried with euhembin. What will be the next?
Thank you for the question. This is not uncommon. Many of the patients with diabetes mellitus are not responding to the drugs. As I told in my presentation time, though the question says that the diabetes of the patient is good control, but if it is not in a target, as the target HbA1c is around 6.5%, and it should be stable. So this patient should have good results. Another thing we should keep in mind that the lifestyle modification should be strengthened in those patients, increasing the physical activity, reducing the dietary components that can negatively impact erectile function, and the sleep pattern. All things should be taken in the account. And another thing is that the psychological part of the patient should be addressed. In those patients who are responding to lifestyle modification and pharmacotherapy, probably we have missed the psychological component at the beginning. So the psychologist can help for those patients.
Okay, thank you very much. My another question from the chat box to Professor Firoz Amin, which is better, tadalafil or sildenafil for diabetic patients?
In fact, that cannot be just directly that which drug is better for my patient, because as you know that both drugs acting on the same receptor. Some is short acting, some is long acting. So it depends upon the patient's atherosclerotic change in the dorsal artery of the penis. If the some of the patients have, whenever we go for the patient with erectile dysfunction, the diabetes patient, and check for the hormonal investigations, thyroid, prolactin is okay, testosterone is okay, then we go for the dorsal artery of the penis pre and post pavlovic injection. And the report one shows that marked arterial insufficiency. So there's a very little chance is by giving the drug, whatever drug we are giving, there's very little response. So it really troublesome for our to treat the patients. What I normally do, sometimes I give the long-acting drug daily or day after day, and whenever they want to go for the intercourse, they just take the short-acting drug before intercourse. So some of the patients shows a very good result in that way, especially those who have no cardiac problem, especially those who have cross atherosclerotic changes, young patients. So it depends upon the patient to patient. It depends upon the atherosclerotic change of our diabetes patient in the dorsal artery. So you cannot tell the direct question is individualized. Sometimes I have to give one or two drugs combinedly in one or two patients, and I found a very brilliant result that they are not showing the good response whenever by taking on only the short-acting drugs. So I make an understanding. Thank you.
Thank you very much, Dr. Firoz. Is Professor Brigadier General Azizul Islam with us? Professor Aziz? Today's panel of experts?
Yes, sir. Yes, sir.
Oh, thank you, sir. Thank you. Thank you very much. The chat box, there is one question I want to ask you, sir. Who will treat primarily ED? Endocrinology, dermatologist, or psychiatrist? Sir, please.
Very important questions.
Sir,
So
please.
the whole session is on how to treat and who will be treating.
Yes.
So the answer is very easy. Now you have to go for the underlying cause, whether it is a primary or secondary or situational. And if it is a secondary, what is the cause behind it? If it is related with the endocrinologist will treat. If it is related with the andrologist, he will treat. But most of the cases of ED is usually psychological. And another point to note, if there is physiological cause also, it has effects on the psychology also. So psychology can play, psychiatry can play a very important role. But if there is metabolic problem or the problems we have been discussing, everyone can treat. Primarily, the word primarily cannot be used here because the root cause should be found out and the treatment will be according. Thank you.
Thank you very much for your very generous answer, sir. Thank you very much for being with us today. Is Professor Habibur Rahman Dulal, President of BAUS, with us, sir, please? Professor Habibur Rahman, today's panel of experts. Sir, are you hear me or are you with us? I think he is not available. So now we'll move to our special guest, Professor Rupin Shah. There are so many questions from the chat box to Professor Rupin Shah. Sir, Professor Rupin Shah, please.
Yes, I'm here.
Oh, how are you, sir?
Very well, thank you. And how are you?
I'm fine, sir. Very happy to see you in this webinar today after a long time. Sir, how long we can continue the PDE5 inhibitor?
Long time. I have people who have been taking it since 1998 when sildenafil was first introduced. So it's fine. Patients often worry, will it harm my liver or kidney or heart? No, it has no harm. It can be taken long term.
So what is the role of alternative medicine for the treatment of ED?
I think that we have very, very powerful agents with the oral PDE5 inhibitors, and therefore alternative drugs have a very minor role.
Thank you very much, sir. Sir, is how to adjust the dose of pentolamine? The Sushil Kumar tendon,
so
he asked
phentolamine, oral phentolamine has been tried and is no longer used. Phentolamine is used only as part of the bimix for an intrapenile injection. And normally you will prepare the bimix so that you have in 1 ml, 30 milligrams of papaverine and 1 milligram of phentolamine. If you don't have phentolamine available, you can substitute it with chlorpromazine.
Thank you very much, sir. Sir, there is 4 drugs available in the whole country, but in Bangladesh, the sildenafil, tadalafil, and vardenafil available. and Avenafil is not available. I don't know Avenafil is available in India or not. Which drug you suggest more for your patients?
So the choice of drug depends on many things: efficacy, side effect of the drug, and the possibility of drug interaction. Earlier, there was a question in diabetes, which drug will you give? That presupposes that one drug is more effective than the other, and many crossover studies have shown that it is not true. A given patient may find one drug to be more effective. So one patient will come tell you, doc, tadalafil did not work, sildenafil worked. Another one will say sildenafil didn't work, tadalafil worked. So you can start with any one drug, and if it doesn't work, switch to the other one. Then comes the side effect profile. Sildenafil is more likely to cause visual disturbance and headaches, whereas tadalafil is more likely to cause back pain and muscle pain. So if the patient has side effects from one drug, you switch to the other and see if they can find that to be more suitable. Finally, if you have an older patient who's on lots of drugs, tadalafil has a duration of action of 36 to 44 hours. And therefore, the duration of interaction with other drugs is longer. So in older patients who are on multiple drugs, sildenafil is better because it has a shorter duration of action. Between sildenafil and vardenafil, not much to choose. They're both equivalent. Vardenafil may be a little more potent than sildenafil. Avenafil you don't have, but if you get it, it's not more potent. The only advantage of avenafil is the onset of action is early, in 15 to 30 minutes. So if the patient is having a lot of unplanned sex, he may prefer avenafil to the other drugs.
Thank you very, very much, sir. Sir, what is the surgical condition causing the erectile dysfunction, like Peyronie's disease or others, and how you encountered in your private practice in India or like this?
So surgical causes of severe erectile dysfunction that need surgical intervention are many. Severe diabetes will be one, severe atherosclerosis, in younger patients, fractured pelvis, penile trauma. All of these would warrant a penile implant. Peyronie's disease actually presents two different conditions. One is where curvature is the main issue, though the erection is good. And there we would be doing either plication or incision of the plaque with a patch to correct the curvature. Or you may have Peyronie's with erectile dysfunction, where we would use a penile prosthesis. We also have men who have a neophallus reconstructed from the radial forearm flap, and they require a penile implant. And then patients who have had priapism, more than 24 to 48 hours duration, many of them will also require a penile prosthesis.
Thank you very much. Sir, another thing, in this era of availability of the PDE5 inhibitor, do you suggest injection, papaverine injection for erection?
Okay, I'm glad you asked me that, because I think injection papaverine should never be used alone. Pure papaverine by itself is very ineffective and painful. And if you do a penile color Doppler or any study or any therapy with pure papaverine, very often you will get wrong results. You have to use a bimix, papaverine with phentolamine or papaverine with chlorpromazine. That is far, far more effective. I have dozens and dozens of patients who have come to me, referred to me because papaverine did not work. They are diagnosed as vasculogenic erectile dysfunction, and we inject a small dose of the bimix and they have a full erection. So a strong take-home message from today that if you're using intrapenile injections, it has to be bimix, not pure papaverine. As Dr. Christopher said, prostaglandin very good, but not practical in India and Bangladesh, not easily available, very expensive, and needs refrigeration. So then, is there a role for bimix in the era of PD5? Certainly, more than 50% of diabetic men will fail to respond to a PD5 inhibitor, but more than half of these failures will still do well with intrapenile injections. We have a large number of patients, a very large number, who are on self-injection, home self-injection with a bimix. If the PD5 tablet doesn't work, they learn how to self-inject, and they're very happy using that to get an erection.
Thank you very, very much, sir. Sir, if any patient need the penile prosthesis, which one is suggest? Either inflatable or non-inflatable, or why? And what is
So,
the advantage or disadvantage of
the main difference between the two is cost. So it's whether you can afford a scooter or a Maruti or a Mercedes. All will get you there, then it's what you can afford. So if you want the best possible erection, certainly the 3-piece inflatable. But in India, for example, that costs about 7.5 lakh rupees. The non-inflatable Shah prosthesis, which is the Indian implant, it costs only 23,000 rupees. So there is a world of a difference in the cost. So if a patient is concerned about cost, I will use the Indian implant with very good results. If the patient says cost doesn't matter, give me the best, then we would use the AMS 3-piece inflatable.
Thank you very much, sir. Sir, one question from the chat box. How can you test the sildenafil test in your office?
So office sildenafil test, very, very, very useful test. I would strongly recommend it to all of you when evaluating young men with suspected psychogenic ED. Give them 100 milligrams of sildenafil, call them back after 1 or 1.5 hours, give them a private room and ask them to fantasize and self-stimulate and watch the erection at 10, 15, 20, and 25 minutes. If they have a good, full, sustained erection, and there is no other medical history, this rules out any organic cause. It helps reassure the patient. It reveals any curvature or deformity. So it's an extremely useful test to use.
Thank you very much for being with us. I will come to you later on for your special guest speech. Now I will switch over to Professor Dr. Yoshikazu Sato. Are you with us? Dr. Sato?
Yes. Hi.
Hi,
everyone.
How are you?
Hi. Good evening.
What is your advice to the patient for to the patient of diabetes or other non-communicable disease will affect in forming the erectile dysfunction? How can that patient prevent the erectile dysfunction? What is your advice and recommendation?
Okay. Basically, my first choice is a PD5 inhibitors. And for a diabetes patient or other comorbidity patient, I recommended a good control for diabetes. And that is one of the very important aspects of the disease. So my recommendation is first choice is PD5 inhibitor, and second choice is injection therapy. In Japan, prostaglandin E1 is very popular for injection therapies. And the third thing is good control for their comorbidities such as diabetes. Okay.
Okay, thank you, sir. I know the people in Japan is so much active. Both they do very strenuous work and they are not lead their sedentary life. So I think that is also help to prevent the erectile dysfunction in some people. So I know you are the organizers of the World Meeting of the Sexual Medicine in this year. So how can you going to organize this meeting?
Okay, thank you giving me a chance for introducing World Meeting, coming World Meeting. Oh, can I share my slide?
Yes, please.
No.
You can quickly, present in within 2 to 3 minutes. Can you? Possible?
Yeah, and
okay.
I sent my slide to our.
Okay.
Okay.
Okay, you can share your slide, please.
Okay. Oh, I'm sorry. I can find my slide. So.
Okay. Then I invite you to talk today's special guest. Please, you can speak your. Okay, say a few words of today's webinar and so on as a special guest of today's session, please.
Okay, we kindly ask you for supporting for this year's World Meeting. The World Meeting will be held coming November 19th, 20th, and 12th. As you know, this is first virtual meeting for World Meeting, and we have very exciting and very timely topics in sexual medicine. So our meeting provide new normal for sexual medicine and COVID-19 corona eras. So we can create a new normal for sexual medicine in these situations. So this is my introduction for World Meetings. So finally, I wish you and SASSM a great success in every situation. And my personal feeling, I really miss seeing you directly, I mean in person. And hope that we can see each other again soon. Thanks.
Thank you, Professor Sato. Hope to see you. Take care and stay safe. Now I invite Professor Dr. T.S. Satyanarayan Rao. He's the Professor of Psychiatry. Please say a few words of today's webinar and also your advice of the regarding psychogenic ED management. Please, Professor T.S. Satyanarayan Rao.
I'm extremely happy for the invitation and to be with you all. And we are all well aware COVID-19 has brought us be away from each other. But somehow Zoom and other platforms have brought us much closer than what it was earlier. So it is indeed, I'm very happy that some of the very important aspects like ED and other related things have been discussed. We are all well aware SASSM is doing a great job, and one of the important aspects is actually to spread the message, both among the doctors and the public, that awareness is brought to this field of sexual medicine. Dr. Rupin Shah is there, and a lot of other people have been doing a great job. So also now Shamsul Hassan has taken up this in a very big way. I'm very happy to be part of this particular thing. Coming to, of course, ED, there was a time when we used to talk about something psychogenic and something organic. Now we believe that it is almost 90% it is a mixed etiology. Maybe about 5% what can be called as purely psychogenic, or maybe another about 5% maybe organic. This particular idea that differs. Initially, we psychiatrists to publish articles telling that many of them are psychogenic only, or almost all are psychogenic. But when you talk about diabetes, hypertension, drugs used in different conditions, and other surgical and other related conditions, we are all well aware the organic factors were emphasized much more commonly. The point is, everybody should be well aware of psychogenic factors, whether we are talking about organic or psychogenic. We did one small study of about 200 patients from the clinic and in the hospital. Almost half of our patients were actually on what we call as this so-called DA syndrome, the misconceptions. These are the type of things extremely common. It means even those who had ED, PE, and other related things, almost 80% of them had a lot of psychogenic factors to contribute, and misconceptions is extremely important. This division into diabetes, psychogenic as a specific problem, and overall introduction given is an extremely good way of reaching the people with an idea. If some specific problem is present, that should be treated. And psychogenic and other related factors as a contributory actually keep in the back of mind. So with these few words, particularly from India, greetings to you all. And more than anything else, this we are all joining together and working on this. It is something very pleasant, and I am grateful for this particular opportunity. Thank you very much, and all the best wishes for the coming programs.
Thank you, Professor Rao. We always acknowledge our Indian friends regarding the development of the
I was there in
urology,
Bangladesh 3 times and
urology, andrology, sexual medicine, so many things, and due to bilateral collaboration. We always acknowledge your friendship and collaboration. Thank you very much. Now I invite Professor Dr. Rupin Shah, who needs no introduction, I think. He's the man of urology from India who devoted himself for the development of the andrology in this subcontinent. He trained so many persons and he treats so many patients. He reproduced the sharp prosthesis and so many things. Now we can hear, we want to hear something from the Dr. Rupin Shah. Sir, please. And we remember your wonderful hospitality in 2011 or 12 in the Bangalore meeting of SASSM. Sir, please.
And thank you very much for the honor of making me a special guest at this wonderful meeting. I remember coming to Bangladesh maybe 20 or 25 years ago with the Bangladesh Urology Society, where we held one of the first operative workshops and featured a lot of andrological surgery. So since then, I've had very close ties and many, many close friends, especially in the Bangladesh Urology Society and a few in the Sexual Medicine Society. So it's a great pleasure and an honor to be part of this meeting. The SASSM School of Bangladesh has been doing wonderful programs, the 2-day programs and the other half-day programs and this meeting. And I think that you will continue spreading the word at different levels amongst specialists, amongst generalists, amongst family physicians. And it's very, very important to get the message across because especially in our part of the world and the country, there is still a lot of ignorance about sexual medicine, sexual dysfunction, both in the lay public and even in the medical fraternity. So meetings like this are very, very important. My congratulations for putting together a wonderful talk session today. I enjoyed all the talks very much. They were excellent talks and educative. And I hope that you will have many other such meetings. Thank you once again and all the best.
Thank you very much. Thank you very much for your wonderful speech and excellent speech as always. When you talk, we all hear you talk as a student always. Thank you very much. So today's meeting, I acknowledge our SASSM School of Urology President, Professor A.K. Manarul Islam, Professor Roshana Begum, and Gynae and Obstetric Society, and then the Dr. Samsul Hassan, who is the keynote person in Bangladesh for organizing the SASSM School. So thank you all the organizers and all the leaders of the SASSM for combining all the faculties to organize the SASSM in Bangladesh. Now I invite such a personality who is no need of introduction today. He is Mr. Mossaddeq Hossain, who is the managing director of the UniMed and UniHealth Pharmaceuticals Limited, who is really a patron of the sexual medicine in Bangladesh. We lot of specialists from the urology, skin and venereal disease specialists, psychiatrists, gynecologists. We went together in the Bangalore in 2011 or 12 in SASSM meeting, and that was the start of sexual medicine group in Bangladesh. And who was the real patron and organizer of social sexual medicine in Bangladesh. Now I invite Mr. Mossaddeq Hossain to say vote of thanks.
Thank you, Professor Tawhid, for a nice introduction. You are our good friend and a very strong proponent of these sexual medicine programs in Bangladesh. So thank you for giving me this opportunity to say a few words as for giving the vote of thanks. Respected Chairperson, Professor Muhammad Farooq Pathan, distinguished special guest, respected panel of experts, learned speakers from home and abroad, respected moderator, and very distinguished participants, ladies and gentlemen. Once again, a very good evening and assalamu alaikum. We really enjoyed this very lively and very successful webinar organized by the Society for Sexual Medicine in South Asia, Asian Society for Sexual Medicine. I think these being participated all the way from Japan, by Professor Yoshikazu Sato, and also from Malaysia by Professor Christopher Ho, and also from India by eminent andrologists and leaders, opinion leaders in the field of sexual medicine like Professor Rupin Shah and Professor T.S.S. Rao. This actually enriched the total program and made this very successful. With the distinguished participants from Bangladesh, I believe has enjoyed. And of course, best of thanks goes to our learned speakers, Professor Christopher Ho, Dr. Shahjad Salim, and Dr. Palash Roy from Bangladesh. They have actually described the most important and pertinent things related to the sexual medicine, the or erectile dysfunction, and what is the response related to patients in diabetes and also in psychoanalysis and psychiatric treatment. So these are very important. Of course, we have our panel of experts from Bangladesh, and this panel of experts included Brigadier General Professor Muhammad Azizul Islam, a very learned psychiatrist from Bangladesh, and also Dr. Firoz Amin, a very learned endocrinologist from Bangladesh. We have missed, I think, Professor Dr. Habibur Rahman from today's meeting, but he is also a very wonderful person as the president of the Bangladesh Association of Urological Surgeons. So we have, I think I will not take much time, but we really profusely and sincerely thank all the speakers for their very nice and timely discussion on the subject. And of course, you have put up all the relevant questions from, I think, the distinguished participants to all the speakers and got very good answers. And I think today's remarks given by Professor Rupin Shah, who we consider as the leader in sexual medicine propagation in South Asia, especially in India, Bangladesh. Actually, when we invited him first for the lectures in Bangladesh, that opened our eye as to the need for sexual medicine in Bangladesh. Prior to that, the society as a whole and also the drug regulators here were very reluctant to give approval for the PDE5 inhibitors in Bangladesh. Actually, that meeting actually allowed us to go to the regulatory authority and sought their advice. They were initially not considering these as pharmacological agents. They were thinking that these were more for abuse potential agents and other things. But finally, we could convince them, and these earlier meetings actually helped us develop the concept here. So as a scientific partner for today's webinar, and also to support the Society for Sexual Medicine in Bangladesh, as well as South Asian Society for Sexual Medicine, we are really proud. And we believe that with your support, with the support of all the leading dignitaries present here, we'll be able to advance the cause of this propagation of sexual medicine's understanding in Bangladesh, and all the society, the Bangladesh Society for Association for Urological Surgeons, Bangladesh Obstetric and Gynecological Society, Bangladesh Psychiatric Society, Bangladesh Society for Endocrinologists, and the Bangladesh Society for Dermatology and Dermatological Society. They have all come forward, put up a unified platform to take up this awareness program and also provide good treatment platform to the patients of Bangladesh. So that, I think, is our success. I thank you once again for giving me this opportunity to say a few words, and we wish you all, the distinguished speakers, the panel of experts, and the special guests for their time that you have given for attending today's very successful and lively webinar. So thank you, respected President, Professor Dr. Mohammad Farooq Pathan, for kindly allowing me to say a few words. Thank you very much.
Thank you, Mr. Musaddiq Hussain. I rather say you are the man behind the machine. That is you are the man to produce the sexual medicine in Bangladesh. So thank you very much. We are always with you, and we appreciate your presence with us always. Thank you very much. And finally, I must give my gratitude and my humble honor to leaders of the SASSM in Bangladesh for allowing me to moderate this session today, particularly Professor A.K.M. Anwar Islam and Dr. Samsul Hassan. Finally, I must give thanks to all the special guests, particularly Professor Rupin Shah, Rao, Professor Sato, and all the panel of experts, and definitely all the eminent speakers. We learned a lot from you. Though erectile dysfunction is a very vast topic, we can discuss so many hours, but there is a time limitation. So rather we will discuss in another day in a very good morning or in very good evening. So thank you very much. Now I invite Professor Farooq Pathan, who is the eminent endocrinologist and one of the pioneer endocrinologists of this country, and who is the professor of endocrinology in Bardem. He is the president of Bangladesh Endocrine Society. I invite him, sir, for his concluding remarks. And one thing I request, sir, there is one question in the chat box. What is the role of testosterone therapy in ED? Sir, please, you include that topic in your concluding remarks. Sir, please conclude the session. And finally, I say goodbye. Thank you very, very much for all the participants and for joining in this lively session. Professor Farooq Pathan, sir.
Am I visible?
Yes, sir.
Okay. Thank you very much, Dr. Tauhid, for introducing me in this today's webinar program. I am very much grateful to the SASSM, South Asia, the Society of Sexual Medicine, to honor me as a chairperson of this webinar program. This is really a wonderful webinar today. In this platform, we have gathered lots of people of different discipline. As you hear from the topics, the erectile dysfunction, it is not a topics of one discipline, it is a topics of multiple discipline approach, because the ED is not a disease itself, it is you can say it is a tips of the iceberg, where the underlying causes are there, and not only that is a predictor of future cardiovascular events also. So what we can say from the presentation of the Christopher, that it is nothing but a health barometer. So it indicates that we have to be serious to evaluate, to assess the problem in a person, whether it is a organic cause, whether it is psychogenic cause. Whatever may be there, if the patient is suffering from organic cause, you have to consider about the psychological component. When a patient comes to a psychologist, you have to also consider about the organic component or mixed is there. So it is a approach should be done to be assessed by the urologist, by the psychologist, by the endocrinologist, and the urologist, everybody. So whatever maybe is there, we have to sit together when a patient is come to us to take a detailed history of the patient. It is more important to take a detailed history, either it is organic or it is psychogenic or the mixed type. Then clinical examination very much important to see the underlying cause is there, not only the problems what patient is saying is not the only things. You have to identify the underlying causes in what may be there and what should be the consequence in future. Together the detailed history and examination, most of the time you can understand the problem quite easily. But little is required for the investigation here. One of the most important investigation to see the vascular cause, to the neurological cause, also the endocrine cause also may be there, and the psychological cause should be taken very meticulously. What Dr. Rao has said, that it is very much important to elicit the psychological component of the patient, either for the patient itself, the jobs, family history, partnership, everything is important here to take in the underlying factors, whatever may be there. And the question is there, one question is there what's asked to me about the testosterone replacement in erectile dysfunction. Not all patients in erectile dysfunction is of the hypogonadism. If the patient is a hypogonadism, whatever may be there, you have to treat, not for the sexual component is only important, but also there is some other metabolic component that's important for testosterone replacement. And testosterone replacement, along with the drugs of what we are using in the erectile dysfunction can be a successful one. Only the testosterone can be the successful one. You have to counsel the patient very meticulously. Not only testosterone replacement is enough, counseling, psychological counseling is important, and the underlying cause also important. So, and the use of other drugs also here. So only one drug cannot help the patient. Just testosterone replacement is not enough. But you have to If the patient has hypogonadism, have testosterone replacement may be one of the issue, not only for the erectile dysfunction, but also other metabolic activities. But we can get benefit from the testosterone replacement, particularly a patient above the age of 50 years also need the quality of life is important here. So with this note, I think so all the speakers and all the expert, the dedicated persons, particularly India and the Japan, who are taking active part in the improvement of the quality of life through this platform, the Society of Andrology or Society of Sexual Medicine. I think so in future we can get more highlight the pathways in that respect so that we can improve the quality of life of a person as a whole. Either is a person is diabetic or person is suffering from other disease also, which may invite erectile dysfunction as a whole. So with this note, I thanks everybody and thanks also the UniMed, UniHealth, and for supporting us as the person in this field, because in one sense we can say that we are all here to serve the people of the suffering the people. So goodbye everybody, stay home, stay safe. Thank you very much.
Thank you, sir. Thank you.
Thank you.
So please stop the sharing.